It's not just about fatigue, and this is really crucial for us to understand because we often tend to think about pacing or activity and then feel fatigued. But what you find in many patients that they often get symptom exacerbation, which means their POTS could worsen, their mixed features, their ruminations, their sleep dysfunction could worsen. Let's look at the revised Canadian consensus criteria. So firstly, we're looking at the illness length. So 6 months, in children it's 3 months. We're looking at persistent or recurring symptoms for greater than 6 months. But it says not lifelong. The key domains are fatigue, and we'll look at the specific descriptions as we go further with the slides. The next crucial component is PEM, post-exertional malaise or post-exertional fatigue, sleep dysfunction, such an important part. And this is often forgotten and actually maintains the disorder in the majority of patients. You see, a lot of sleep dysfunction is associated with hyperarousal, which over time moves up the mesolimbic hierarchy. Sleep dysfunction is a proxy in the initial stages circadian rhythm, but as it worsens, it creeps higher up the mesolimbic hierarchy. So patients can move along the lines of mixed features and hyperarousal and agitation. There are different ways in which pain is described. Certain kinds of headaches are mentioned behind the eyes, but also other pain syndromes. And this is where many patients may be labeled as somatoform or somatic symptom disorder, the new DSM-5 term. This pain also has fibromyalgia within it. And we have hyperalgesia and allodynia. Essentially, allodynia is the component where a certain stimulus should normally not be painful, while in allodynia, that particular stimulus is painful. This constellation usually has fibromyalgia associated with it, but it doesn't need to be diagnosed fibromyalgia through a rheumatologist through specific points, etc. They can simply just have hyperalgesia or allodynia without fibromyalgia. Then cognitive dysfunction, another really crucial component of chronic fatigue syndrome that we can target effectively. And what's important here is that all of these are actually related from a pathophysiological point of view. Cognitive dysfunction is linked to sleep dysfunction. Cognitive dysfunction is linked to fatigue. Cognitive dysfunction is linked to pain as well. The next one, in addition to these symptoms, you have one symptom from two of the following three categories. Autonomic nervous system dysfunction, where you'll have terms such as orthostatic tolerance mentioned, or POTS, postural orthostatic tachycardia syndrome. You have neuroendocrine dysfunction and immune dysfunction as well. Many patients have a range of immunological disorders, and this is where mast cell activation is one of them. Now, the international consensus criteria, I look at both domains because patients will present with a whole constellation. So what are the domains according to the international consensus criteria? The first one, PEM. We've got post-exertional fatigue. The symptom exacerbation can be across the board. They also use the term PENI, which is post-exertional neuroimmune exhaustion. The recovery period is prolonged. A relapse in the context of PESI or PENI can last days, weeks, or longer. When I'm treating the higher end of the spectrum, I will have a very low threshold for admission, particularly if they're extremely unwell, a heightened arousal, a significant pain syndrome, significant brain fog. I will usually consider admission. The reason is to modulate or to be able to control this PESI and PENI. Because what happens in the outpatient, the environmental stresses, we have no control over it. And one of the things that happens, you can see these somatic symptoms, they often tend to have hyperalgesia, allodynia, but also increased sensitivity to medications. You'll notice in clinical practice, you might prescribe medication and much of that can sometimes be perceived. It's not that it's in the patient's mind, they actually feel it. They may come back to you and say, I've experienced a side effect. And this may not actually be a side effect. It may be a misattribution at times. Now, that's not to say that if we prescribe a medication that's incorrect, for example, in hyperarousal, and we prescribe activating agent, of course, they're going to have worsening of hyperarousal. But if we're fairly certain that this should not have that particular effect, then often PESI can be playing a significant part that results in heightened somatic sensitivity and often misattribution of certain somatic symptoms as side effects. So do keep an eye out for that. I tend to have a very low threshold for admission this particular condition.